next abstract is looking at molecular analysis-directed international phase 3 trial in patients with advanced non-small cell lung cancer. This is looking at two particular markers, ERCC1. And ERCC1 has been proposed as a marker of sensitivity to platinum drugs. So the platinum drugs that people typically will receive are either cisplatin or carboplatin. The platinum drugs lead to DNA adducts, and those can be repaired by, among other things, a complex involving the ERCC1 gene. Repair often indicates that something is a positive, but if you're giving a chemotherapy with the intent of damaging DNA, you would, if you had your choice, not have repair. As a result, it has been purported that high levels of ERCC1 indicate a lesser likelihood of response to platinum drugs, both carboplatin and cisplatin. This is a complicated slide, and I'm not going to go into it in great detail, just to say that RRM1 has been proposed similarly to be a marker of sensitivity to the drug gemcitabine or Gemzar. I think that the authors of this study deserve a great deal of credit for the design of this study. I am sure that Jack and David have had similar experiences of someone who has a predictive biomarker that they come in and they try and convince you that you should be using this predictive biomarker. When that happens, I generally recommend that if they want me to use a predictive biomarker, they design a study like this. And in general, I never hear from them again. But to the author's credit, they in fact did run the study. The reason that the vendors often don't look at this is that they take the idea that their predictive marker is predictive as being self-evident. I tend not to believe that. I need to see proof of that. And so the proof of that would be to do exactly what they have done in this study, which is that you believe you have a predictive algorithm and you test it against basically not using your predictive algorithm. And this is a complex slide, but if you look, they stratified patients by ERCC1 and RRM1. All patients were required to give a diagnostic biopsy. So they either had to have a biopsy or they had to undergo a fresh biopsy. And the authors also deserve to be commended because I believe that there were 53 patients on this study that needed to undergo a fresh biopsy in order to enroll, and 47 of those 53 did. So they had a very high rate of patients who were even willing to undergo a fresh biopsy to participate so that one could test these biomarkers on their tumor. Again, since low levels of ERCC1 were felt to be predictive of sensitivity to platinum drugs, carboplatin was used on the left, which was a 2-to-1 randomization. So twice as many people got the targeted approach rather than the standard approach. Now, as you can see over on the right, the standard approach, which was received by 1 out of every 3 people, they just got gemcitabine and carboplatin. But in the targeted approach, they received gemcitabine or Gemzar if their RRM1 was low, and platinum if their ERCC1 was low, and they have the box in the lower right-hand corner, got neither drug. Docetaxel or Taxotere substituted for the drug that was felt to be ineffective based on ERCC1 or RRM1 status, and then that box in the lower right didn't use either Gemzar or carboplatin, used instead Taxotere and vinorelbine, which also goes by the trade name of navalbine. Their primary endpoint, they were looking for progression-free survival. And what you can see here as a result was that, unfortunately, their goal was that they would target people more appropriately by using their targeted approach. They would give them a tailored treatment that was more specific to their tumor. The results did not show that. Numerically, if you look at the curve, if anything, the control arm, the arm amongst patients who were not receiving this sort of tailored approach, was, if anything, numerically a little bit better, but they were not statistically different. They statistically looked about the same. And in terms of overall survival, again, there appeared to be no benefit for determining therapy based on these markers. Now, I will say in addition, and I don't want to get too much into the details because this does become quite complicated, but there have also been some recent questions about the testing mechanisms that have been used, particularly for determining ERCC1 levels. As a result, the conclusion I think that would generally be drawn from this is that this was a negative study and that, in fact, there was no benefit to this tailored approach. The authors, as authors often will in a situation like this, will try to look through their data and find a way in which the data looks better than what is initially presented. And in this case, what they did was that they looked at patients who received gemcitabine or Gemzar plus carboplatin. Now, In the control arm, everybody received that therapy. However, in the study arm, only the patients who had ERCC1 and RRM1 low received that. So in the patients on the control arm, they also had a group in that upper left-hand corner. So they just compared those two groups. And they found that, in fact, that there was a better outcome in the control arm, and that was significantly better than the experimental arm in this group of patients. Now, this group of patients should have been identical to the other. As a result, they conclude that it's sort of a false interpretation. Now, a few things to caution on. They show here the p-value, and a p-value for those of you, and I know this is a very sophisticated audience because I certainly see patients who are coming from this venue in my clinic, and I know the extent to which they know details about their care about studies. A p-value of basically 0.02, which is means that results this disparate would be seen by chance in only 2 out of 100 cases. So in many respects, certainly looking at this data, you would concur that the authors and the designers of this study got a bad break, that the patients who should be absolutely identical did better if they were on the control arm than the experimental arm, even if they got the exact same therapy. So that's a result that unfortunately went against them and should have been exactly the same. However, if you look at the other groups, still there is no particular difference. So I think the end result of this study was that, and unfortunately I list the conclusion slide. This is the only study in which I list the conclusion slides because I think it's important because they drew the conclusion that this trial was a false negative trial. I think that is a somewhat dangerous conclusion in the sense that this trial was a negative trial, and I think that the end result from this is that you have to consider that ERCC1 and RRM1 are not ready to be used in a clinical setting for decision making. They propose at the bottom, which is possibly true, that better tools are needed for assessment of these targets, and I certainly have no disagreement with that. The one thing I will point out, as I know that many of the people who are calling in are either affected by this disease or have loved ones who are affected by this disease, I always tend to caution people because many of you may have gotten reports back from a tumor that will incorporate data on ERCC1 status or RRM1 status. And as a result, these reports from commercial vendors will say that as a result of this test, the patient should not receive platinum, or as a result of this test, the patient should not receive gemcitabine or Gemzar. And as you can see from this data, the best available data to date does not indicate that that is true. And so I think that as we get more molecular testing in lung cancer in particular, I think we have to be very cautious. I don't think anyone would argue that the result of an EGFR mutation test is not particularly relevant. But I think that today the best available data would indicate that the result of an ERCC1 test is not clinically relevant. And when you get the report back from a commercial lab, it doesn't necessarily indicate that. It doesn't indicate that one is clearly predictive while the other is not. And so this is an aspect that I think does have direct relevance to patients, and so that's why I spend a little additional time on it.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our GRACE website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.